This is stylish designer hairspray. But we're not talking about that today. Oh, eye. Oh, my eye. Ooh, oh. Welcome to cancer. I always start my cancer talks by illustrating the pathogenesis of cancer as occurring when an imbalance happens between the two gene categories that promote and regulate cell growth. On one side of the equation are oncogenes, genes that code for cell growth and division. Keeping oncogenes in check, tumor suppressor genes. Now there's a concept we all need to have cemented. The cartoon video we watch on abnormal cell signaling in cancer cells does a great job of making a cartoon out of things. The reality of it is cell signaling is massively complex. You were introduced to it in anatomy and physiology, and here we have a couple pictures to re-illustrate the scariness of cell signaling. I, however, like to keep things kind of simple. So this is my attempt at a cartoon representation of a normal cell signaling process. The process starts with a signaling molecule, which we call a ligand. And a ligand could be anything. Insulin acts as a ligand, and it starts a cell signaling process. Growth hormone can act as a ligand and start a cell signaling process. Estrogen, progesterone act as ligands and bind to proteins within the cell and start cell signaling processes. In fact, ligand binding and cell signaling involves this kind of intracellular lily pad of proteins, eventually leading to the nucleus, upon which DNA is transcribed and proteins are translated. Now, cancer is a result of abnormal DNA. In some form or another, the genes and gene expression has changed. In many cancer cells, mutations to the intracellular cell signaling proteins, write this down, allow those cell signaling proteins to signal downstream for genes and proteins that make the cell grow and divide in an uncontrolled way. Remember from A and P, growth and division of a cell is a tightly controlled process. But if you introduce a mutated protein into that process, the control is lost. And in some cases, in the cases of cancer, that mutated protein can send that growth and divide signal down to the nucleus in an uncontrolled capacity. Two other cartoons during Cancer Week have to do with apoptosis, or programmed cell death, and angiogenesis. A cancer can only get so large before it needs to turn on genes to create new blood vessels. If it can't turn on those genes, the cancer is very limited in its size capacity, and in fact might not actually grow to become a true cancer. Apoptosis and the potential for apoptosis exists in all of our cells. Cancer has a unique way of manipulating the proteins that regulate that cell signaling pathway in its favor to reduce apoptosis and allow the mass itself to survive when it shouldn't. The third video in the cancer cartoons has to do with how cancer successfully spreads throughout the lymphatics and the bloodstream to metastasize to other parts of the body. This is a real important thing to note in terms of how it translates to your clinical practice. We're focused on the how and the why in the pathology class. But when you're in clinical practice, knowing which cancers metastasize most commonly to which places is an important way for you to ask the best nursing history questions when you're working with patients. I'll give you an example. A patient with breast cancer was treated, let's say 5 years ago, and has been declared cancer-free after her treatment, which ended about a year or so after her diagnosis. She's now in your primary care clinic and she's complaining of new lower back pain. Let's say this woman is 58 years old and has had a desk job for the last 20 years. As you're doing your nursing history, it would be very easy in a busy primary care clinic to say, well, she's older, she has lower back pain probably from her desk job. That's what's going on. But knowing that breast cancer commonly metastasizes to the bone is very important to make sure that this particular patient deserves the attention to that back pain and the workup that it requires. So, cancer is the result of genetic changes or epigenetic changes, as we'll see in a few minutes, that affect gene expression and the genes themselves. Let's add two terms to your vocabulary: somatic and germline genetic mutations. The definitions are right here. A somatic mutation is a mutation to DNA that we take on sometime during our lives. It's isolated to the cell in which the damage occurred. Contrast that with a germline mutation, which is a mutation present in an egg or a sperm. All right? When those two things come together, it creates an organism that has that mutation in every cell in its body. So how do we get genetic mutations? What is going on here? I don't want to be mutated. Hey, genetic mutations happen spontaneously all the time. To some extent, we're all getting them here. However, lifestyle plays an important role as well. In the category of modifiable risk factors, being sedentary, being obese, which is a pro-inflammatory state, eating very few fruits and veggies, which are loaded with antioxidants and reduce free radical oxidative damage, are things that we know increase risk for DNA damage and thus cancer risk. Those are modifiable risk factors because you can change them. Non-modifiable risk factors, you can't. Age is the classic non-modifiable risk factor. As we age, we're going to accrue more genetic mutations. It's just going to happen. The genes you were born with can put you at higher risk for certain cancers. You can't change that. Related to the genes you were born with is your ethnic background. And we do know that some higher risk cancer genes occur more commonly in some populations than in others. I don't know, man. I'm just totally getting the feeling everyone's looking at you right now and not me. Not really too sure why, but everyone's just looking at you, not me. Look, I'm the lecturer. One scary thing to note, in case you weren't aware of this already, back in, I believe, late 2015, the International Agency for Research on Cancer gave red meat, and especially processed red meat, think salami and stuff like that, its level 1 carcinogenicity rating, meaning a substance that research has enough valued evidence to say it damages DNA, specifically of the colon, and puts people at very high risk for the development of colon cancer, especially in meat-based diets. One thing I'm not going to get into too much in this class is subcategorizing the various mutations that occur. If we had more time, we would definitely get into it because not all mutations impact the protein and the protein's functionality in the same way. Those of you that are interested, however, please do some research on your own and take with you this concept. A gene can be mutated. That doesn't always guarantee that the resulting protein is non-functional and can't perform its job. Okay, this is an important one, so write this information down. The point of initiation of genetic alteration, whether that genetic alteration is a mutation through DNA damage by carcinogen exposure, maybe it's a spontaneous DNA mutation, maybe it's an epigenetic change to gene expression. We'll talk about epigenetics in 1 minute here. Or other ways that we damage DNA. All right, when that happens, there's 3 potential outcomes that I want you to consider. All right, the top arrow indicates potential outcome number 1, and that is upon damaging DNA, perhaps irreparably, the cell undergoes apoptosis. Outcome number 2, which is the middle arrow, upon sustaining DNA damage, the cell repairs the DNA damage. I should tell you right now, most tumor suppressor genes and their related proteins work in the DNA repair shop. And that's how they prevent uncontrolled growth through cancer. They repair damaged DNA, keeping the cell normal. Potential outcome number 3. The DNA damage is not repaired, apoptosis doesn't occur, and that DNA damaged cell is allowed to continue growing and dividing, growing and dividing. I probably don't need to say this, but outcome number 1 and 2 are the good outcomes. Outcome number 3 is the poor outcome because it could potentially lead to cancer years down the road. Now, you've probably already touched on epigenetics in other classes, so I'm just briefly going to reiterate things. Epigenetic alterations to DNA impact the DNA or gene's expression or ability to be expressed, transcribed, translated, but don't actually change DNA at all. We're not going to cover every mechanism of epigenetic alteration, but we're going to focus on the 2 most common. The first one is the use of methyl groups attached to cytosine on DNA. If you look at the picture, you can see the little Me symbol attached on the outside of the DNA. The effect of this is essentially to stop or halt transcription at that point on the DNA. If you halt transcription, you don't get proteins. You're essentially turning genes off in that way. The other mechanism illustrated in this picture is taking DNA and wrapping it tightly around the histone proteins. The tighter that DNA is wrapped around those histone proteins, the less accessible the DNA is for transcription. If DNA can't be transcribed, no protein is made. Now, in many human cancers, the cancer itself will find a way to epigenetically modify its genotype. For example, turning off a tumor suppressor gene by just binding a bunch of methyl groups to it. We see that with the major tumor suppressor gene, protein 53 or P53. Sometimes cancer can turn on a gene that was previously silenced. And a common example here is carcinoembryonic antigen, or CEA, a gene/protein that is responsible for fetal gut development and is normally silenced in adults. Many colon cancers express CEA protein. So the term initiation describes that genetically modifying event that could go on to lead to cancer. Initiation also has to be concurrent or co-occur with something that cancer pathologists call promotion. That abnormal DNA cell has to be in an environment that promotes its growth and division. the most common source of promotion is chronic inflammation from things like dietary fat and being obese, tobacco smoke, alcohol, but hormones too can be an agent of promotion for cancer cells. Most commonly, and probably most reputedly, in breast cancer, where it uses estrogen, for the most part, as an agent to promote its continued growth and division. I'll just let you read this little blurb here and see if you can fill in the blanks yourself. I guess it's quiz time. So the terms on this slide can be a little bit intimidating to people. Let me try to break it down a little bit simpler. The question is, hey, if I've got cancer, why doesn't my immune system just recognize it and knock it out? And it's a great question. So here's the answer. Answer number one, sometimes your body does do that, and my body and our patients' bodies. That's cool. Matter of fact, that probably happens more often than not. But in some scenarios, the immune system isn't finding cancer, and that's why we have cancer diagnoses. So, is that a result of the cancer itself not producing proteins on its cell surface that the immune system can recognize? That's called loss of antigenicity. There's just no proteins that white blood cells, lymphocytes, neutrophils can bind to say, you should not be here, kill, kill, kill. Scenario number two, maybe the cancer does express antigens. Those antigens are depicted there as little red dots, but those antigens are not something foreign enough for our immune system to recognize as something that should be attacked. Scenario number three, and there's a lot of research in here right now, involves the cancer itself training neutrophils and macrophages to essentially create its own microenvironment. And that microenvironment is immunosuppressive. It has its own police force of macrophages and neutrophils, and that police force actually suppresses other aspects of the immune system from coming in and taking over its territory. When you work with cancer patients, you will see the TNM classification schema used to describe three things about that patient's cancer. The tumor size, which is part of the T classification, whether or not regional lymph nodes have cancer cells in them, and whether or not there are presence of metastasis. With regard to lymph nodes specifically, regional is the key term there. It's got to be lymph nodes that drain that area that the cancer occurred. Right? If a patient has a cancer in the lung, you're not going to be looking to lymph nodes around the kidney to see if there's lymphatic involvement. You specifically look to lymph nodes that are draining that area of the lung tissue. Now, the TNM classification is what clinicians will use to arrive at a stage. And stage is what patients know all about because they're reading it on WebMD and on doctor.com, and that's what they're asking you about as a clinician. Nurse, what's the stage of my cancer? So I give you brief definitions. The other thing I'll add to these definitions listed here is that stages 0 through 3 are considered potentially curable. Generally speaking, stage 4 is not. You seek cancer control, but an absolute cure is, generally speaking, not something that can be achieved. One other thing to mention, cancer at stage 0, cancer in situ, what that means is cancer sitting in its original place, maybe it's the breast ductal epithelium, maybe it's the lung epithelium, and it has not shown any evidence of invasion of local tissue yet. And for those of you who are wondering, breast cancer, specifically ductal carcinoma in situ, DCIS, is the most commonly diagnosed cancer that is found at stage 0. I, every year when I do the cancer talk, I have people go, "Oh man, that cell signaling stuff. We're not the biochemists. Why are we learning this?" Oh, and I was totally the same way. Just so confusing, these proteins and everything. But here's the gig. Here's the gig. When you're a nurse, you're giving drugs and you're responsible for knowing how those drugs work. In cancer, and actually now in other diseases as well, nurses are administering medications that modify cell signaling. One huge category is called monoclonal antibodies. And as the name implies, they're synthetic antibodies that go in and bind to a specific protein receptor on the outside of a cancer cell. And in so doing, they block cell signaling to go through the cell and send that signal for growth and division. Another big category of medications are called tyrosine kinase inhibitors. They're small molecules that are able to diffuse through the cell membrane, and they bind to intracellular proteins, but they do the exact same job as monoclonal antibodies. They stop cell signaling. So whether we're talking about breast cancer, colon cancer, lung cancer, prostate cancer, brain cancer, any cancer, I really want to hammer home this central principle of patho, in that cancer is a result of an imbalance between oncogenes and tumor suppressor genes. There's lots of ways to create that imbalance, but this is the principle of pathology that we're carrying with us to learn about cancer as a whole, because it applies to all cancer.